All right, well, good afternoon and welcome everyone to the Chagas Disease Echo. This is the second in our series, our One Health series. So thanks so much for joining us today. My name is Andrea Roche. I support the Echo program here at UT Health San Antonio, and we're very excited to be partnering with San Diego State University, Texas State University, and the South Coastal Area Health Education Center, the AHEC, to support these sessions. I just have a bit of a housekeeping before we get started, really. So we are recording these sessions. You should have just gotten that notification for later distribution through our YouTube channel and through the Chagas Echo website dedicated to this series. I want you to know your names don't appear on the recording, and anything you mention in the chat also doesn't appear in that recording. To help us with attendance, please do enter your name and your affiliation and email into the chat function to help with our record keeping. Know that if you've joined by phone, we might be calling you after the session just to confirm your attendance and help with our records. We encourage everyone to join by video during the discussion portion of our sessions, which happens after our didactics and after our cases. That said, we're happy you're here regardless of how you connect. So we encourage you also to speak, but do ask that you stay muted unless you are speaking. To mute and unmute in Zoom, just navigate to that microphone icon in the bottom left of your Zoom screen and click it. If you've joined by the phone, I don't think anyone has, but if you have, just press *6 and there's a little bit of a lag, but you'll hear a loud voice telling you you're unmuted. You can also communicate with the chat feature to raise questions, or if conversation is quite lively, navigate to that reactions menu in the bottom of your Zoom screen, and you can use that to either raise your hand or make a signal that you'd like to speak. But we're a pretty welcoming group here, so you can probably just feel free to unmute and raise questions too. Partway through the session, we're going to send out a link to a post-session evaluation survey. Please fill it out. It helps us shape this series and refine it to meet your priorities and your needs. And it's also a way of earning free continuing medical education for participating in the session. So make sure you fill that out. Finally, for those who might be new to ECHO, the acronym stands for Extension for Community Healthcare Outcomes. This is a model of telementoring and lifelong learning that connects community-based health workers and professionals with each other and with a multidisciplinary team to create these communities of practice and learning. Our aim in these sessions is to build capacity for delivering best practice care. And we do this through a pretty standard format. Delivering some didactics on a key topic like Chagas and discussions of real life cases, followed by dynamic conversation with all of you to explore and unpack and discuss strategies for addressing those cases. ECHOs thrive on conversations that acknowledge and include the perspectives of many disciplines and professions. So with that in mind, we welcome everyone's questions and experiences and perspectives in today's conversation. I'm going to pass things over now to Dr. Stigler-Granados, who facilitates these sessions. And while she's unmuting and introducing, Carly, if you wouldn't mind sharing that opening announcement deck. Great. Paula, floor is yours.
Thank you, Andrea, and welcome everybody. I'm super happy that everybody's here. I'm Paula Stigler-Granados, and I am at San Diego State University now, previously at Texas State University, and I'm really happy to be facilitating these sessions on Chagas disease in the United States. This is a One Health series that we've put together with support from the CDC in order to be able to have these sessions and have our experts with us to introduce these important topics to everyone. I highly recommend utilizing the chat feature to have communications with everyone in the group. We have quite a few experts that are joining as participants here. I see you and I know a lot of you, and I'm really grateful that you're here. So please feel free to have those discussions. If you do have any questions that you want to ask the speakers, I can also help facilitate that. If you put that in the chat, then I can ask that they respond to those questions when there is a moment. So thank you all for being here. And I'm really grateful to have you here. So can you advance to the next slide, please? This is our disclosure of relevant financial relationships. We have none that were reported, and we just wanted to make you aware of that. Next. And this is just our agenda here. So we're going to have our first presentation from Dr. Melissa Nolan, who I'm about to introduce, and then we'll do a quick case presentation, clinical information from Dr. Natalie Bowman. We can do a Q&A at the end. We can also do a Q&A in the middle, whatever seems to work best. We only have 1 hour, so we will try to keep things, on track as best we can. And also for the speakers, if we start approaching around a 2 or 1 minute mark, I may interrupt you. As much as I hate to do that, I might have to just pop in real quick and just let you know that we're running close to time. So I think that is the next slide, please. And this is, just wanted to show you this. I think probably most of you are familiar with the concept of One Health. This is a graphic that the CD has put together. It's, One Health is mostly, these vector-borne diseases, zoonosis. Obviously, we're even in the middle of a pandemic still, or some people say we're coming out of it, that has to do with the zoonotic disease. And so One Health is a really important umbrella, especially for these vector-borne diseases like Chagas disease. So that's just an informational slide there. Next, please. And I'm super excited that we have Dr. Melissa Nolan with us. She is a good friend and colleague, and I miss seeing her in Texas all the time now, but she is now in South Carolina. Her research interests lie in infectious diseases and health disparities, and her work focuses on patient-oriented public health approaches to tackle diseases that disproportionately affect the impoverished. Her current projects are focused on clinical epidemiological characterization of Chagas disease in the United States, in Mexico, and Central America. She has a lot of wonderful publications and has really brought to light a lot of evidence about Chagas disease in the United States. So I'm super grateful to have her here with us. And with that, I think we're going to actually ask you all a couple of quick questions before we get started. As we said, we like to have these be interactive sessions. And so Andrea, do you want to do that?
Yeah, and I think the way we built in our polls, Paula, we're going to ask one right now, and then the other set, if they're bundled together. So Carly, would you mind just launching poll 2, the 1-question-1 here? And you all should see a window pop up on your Zoom screen. And a quick question for you, just it's estimated that there are 300,000 people living in the US that have Chagas disease, mostly coming from other endemic regions and countries. Is this accurate? We'll keep the window open for a little bit. We like to get, I always aim for 75% participation, and we're almost there, so. Holy cow, you all are setting the bar very high for future sessions. I think that's pretty good. We got 90% participation. Carly, would you mind ending the poll and sharing the results with the group? All right.
All right, so it looks like we have about 57% feel that this is probably an underestimate. And then 22% said it's probably accurate, 8% no, this is probably an overestimate, and about 14% are not sure. So thank you all for your responses. These are really sort of for us to gauge our audience and just kind of get everybody thinking about this. And with that, we will turn it over to Dr. Nolan.
Thank you. Well, it really is a joy to be here. I've long enjoyed working with Dr. Stigler-Granados as well, and certainly very impressed. Can't believe it's been 7 years already, Paula, that you've been doing such important outreach, and it's great to see colleagues that I recognize and new colleagues in this as well. So hopefully you'll find today to be entertaining and educational as well. I have 24 slides, so I promise not to do too many for you. And I will. So just for those that might be new, I have a 1-slide introduction to Chagas disease. It's a parasitic infection. It's a kinetoplastid. So there's 2 clinically relevant forms of this parasite. So on the bottom left, you see the trypomastogote form. This is what circulates in your bloodstream, which then it will eventually find a smooth muscle host tissue site that it likes to go dormant into. And that's going to be on the top left corner. That's your amastogote form. And so this is where it can clinically replicate, divide. It will eventually become too enlarged for the smooth muscle tissue that it's within. It will then burst out, causing fibrosis, and then it will egress to a new tissue site. And this cycle will continue throughout the course of someone's lifetime unless they get treatment. Unfortunately, though, we don't understand why about 30% of people will go on to develop long-term clinical disease, which can be manifested through organomegaly, most often through the heart, so Chagas, cardiomegaly, but you can also see it in the gastric system as well. There's a variety of ways that this is transmitted, but it's most often associated with a vector-borne transmission. So as you see in the middle left, that's a triatomine insect. There's about 136 different species that can transmit this, which is why Chagas is such a large issue throughout the Americas, because there's different species that some like to live in people's homes, some like to live in palm trees. They can live in a variety of settings, but in essence, all of them take a blood meal. And at the same time, to make more room inside, they will defecate the excrements of what's inside their stomach. And that is where the parasite is. So it's not actually through the bite itself, the way that a mosquito would transmit Zika disease, it's through the feces. So with that, it's not a perfect or a very efficient transmission system. So you often see people that have constant or routine exposure before they actually develop clinical disease. And then on the bottom right-hand corner, this just kind of shows you that typically we think of this disease throughout Latin America, but today I'm going to talk to you guys about this infection in the United States and what it looks like. And I believe we were going to do one more poll at this point.
Yeah, let's go on and do that. I think Carly was able to, which one was it? Carly was able to launch it. So poll 1, which is, can Chagas disease be transmitted in the United States? And this group has shown that it can have 95% poll participation. So I look forward to the same. All right. I think that's some pretty great participation. Carly, you can go on and end that and share the results. Resounding yes. All right.
I guess you guys have already given away what the next couple slides are going to be. I'm going to talk to you about 2 kind of recent studies we've done looking at locally acquired or autochthonous Chagas disease in the United States. But first, just to kind of set the framework, up until a couple years ago, we knew that there were 7 autochthonous cases, so 7 locally acquired cases. Most of those happened in Texas, California, Tennessee, and Louisiana. We have known that there's 11 vector species in the geographically southern United States. This actually dates back to the 1850s. So certainly climate change could be a component of this, but we know these bugs have really been here for a long time throughout the bottom half of our country. We also know that there's known sylvatic transmission and that's been occurring in several states. I would anticipate it's happening, this sylvatic transmission between the insects and wildlife is likely occurring in other states, but Chagas disease by and large is not very well studied. So until we have investigators, in different parts, like Nebraska, for example, until we have people in these areas that are researching it, there's big gaps in our knowledge. But generally speaking, there's 4 vector species that I think of that are really important in the role of Chagas ongoing transmission in the United States. That's Triatoma protracta, which is the green you see in the bottom left, kind of in the southwest. There's Triatoma rubida, also along that Texas-Mexico and southwestern border. There's Triatoma grastaceri, which is a really fascinating one, and that mostly only occurs in central Texas. And then there's Triatoma sanguisuga, which we see all throughout the southeastern US, and that has been less commonly associated with human transmission. So one of the first studies I did when I was really actually going through my dissertation at the time was looking at whether or not Chagas disease could be locally acquired by working with the blood banks. So back in 2008, 2010, it started becoming mandatory and required that blood donors had to be screened the first time they got tested. And so with that, we worked with the Gulf Coast and the South Texas Blood and Tissue Center. So we were able to capture the Houston, San Antonio, and down to the Corpus Christi area. So they sent out letters on our behalf to blood donors that had tested positive. We enrolled them to do an epidemiologic investigation. And then we did cardiac evaluations to see whether or not these people might have heart disease as a component of having Chagas. And so in summary from this, what we found was a large evidence of locally acquired transmission. So on the left-hand side, that was our evidence table to try and compare all of the case patients that had evidence of locally acquired transmission. We defined that as having never left the United States or having non-significant travel to Latin America. And so as you can see, each of these rows is a different person. And then across the top, we had general themes of how people could be infected, transmission themes. And a couple of those that kind of came out to us was rural residents. So on the bottom right-hand side, that's a map. Each of the red dots represents a locally acquired case. And what you can see is, and this is Houston and San Antonio, which are about 3 hours apart. So it's a pretty big geographic distance. And you don't see any focalized clustering, but we do see in general, all of these people mostly lived in very rural areas. So again, likely interrupting that potential sylvatic transmission cycle. We also found some evidence of occupational, so people that work for Fish and Wildlife, for example. There was some concern that it could have been associated with a military branch out in San Antonio, although that was never officially confirmed. And then generally speaking, people that might be outdoors working at 2 in the morning or during peak activity time. But within this cohort, there was some thought that potentially this parasitic strain that's in the United States is not competent to be able to cause cardiac disease. Even though I won't show it here, we did find evidence of 2 different DTU types or discrete typing units, meaning that there's a mix of the different parasite genotypes that we have in locally acquired cases. And both of those have been known to be potentially associated with cardiac disease, although the research on that is still really underappreciated. But essentially what you can see here is that we did find within this cohort evidence of locally acquired, or I'm sorry, evidence of cardiac disease. And when you think of a blood donor, you think of them being pretty healthy, right? So you wouldn't think that about 41% of this cohort could be having evidence of locally acquired cardiac disease from Chagas. So this is really a missed opportunity for us to be able to not only identify patients that have already been identified from a blood bank, but then we lacked that follow-up clinical care. In fact, about a quarter of blood donors that went to their doctors from this cohort had any follow-up care done. A lot of them, their doctor said they were false positive. And I will go into this a little bit later on, some of the challenges with diagnostics. But in general, for any of the physicians out here, if someone comes to you with a positive blood bank letter, a referral letter, I would encourage you to follow up to at least confirm infection as the next step. So Texas is certainly an area that I would say there's a lot of potential locally acquired cases going on, but we wanted to say, what about the Southwestern US? So as you can see in this map here, the darker blue gradient is associated with a higher number of triatamine species in the same county. So you can see that really along that Southwestern US-Mexico border, there's several counties that have multiple triatamine species. So it's not just one. So in theory, you would have more potential exposure. And so we wanted to understand if what we were seeing in Texas with the blood donors was continuing along the border. And so with that, we worked with the American Red Cross and Vigilant Blood Systems. Those are larger national blood banks to understand. And same thing, we did a referral out. So they sent letters on our behalf. Anyone that was interested contacted us. We sent this in Spanish as well for both cohorts so that we would get a fair representation. And in general, some of the things that we found that were interesting to us was a lower overall locally acquired transmission rate. So it was about 17% of people in the Arizona, California, New Mexico cohort had evidence of being locally acquired, compared to about 53% in Texas, which was pretty dramatic to us, especially since we had similar numbers in both of them. And even within this Southwestern US cohort, we still found that about 40% of them had evidence of acquiring their disease in Texas. So these were people that maybe currently lived in California, but had spent formidable time in Texas or had recommended or noted that they might have had transmission there. So that was pretty interesting to us. Within this cohort, we also found less evidence of rural residents, and we found more evidence of potential sylvatic transmission. So camping in particular, again, really interrupting going out into that natural transmission setting. And so we found that to be an interesting component of the Southwestern group. We also found fewer cardiac findings in this group, which was interesting to note, but sadly, a similar low treatment rate as well in this group. so part of this, if anyone's ever been to Big Bend National Park, it's really kind of right along that divide. It's on the edge of Texas. It's close to the Mexico border, but it's also kind of going into the southwestern landscape. It borders New Mexico. And so we were invited to come out. There were a couple dogs that had been identified out here as being Chagas positive. I believe one potentially had passed away. And so the local National Park Service people were really concerned because they were having exposures to triatomines. And in fact, if you go back in the historic literature, all the way back to when Big Bend was first established, there's several stories and accounts of those people being exposed to triatomines. So we knew this was a potential hotspot. And so we went out there, we enrolled residents that lived within the national park, so those that were employees, but then we also enrolled those that lived in nearby Terra Lingua, which would be a different mix for the most part. It was typically associated with a lower overall socioeconomic status for those that lived outside the park because they weren't employed by the Park Service. And so with that, we found a high rate of Triatoma rubida. So it's a different species. We didn't find as many Gerstackeri. Then we found these again had TC type 1, which is no surprise. But interestingly, of the 85 people we enrolled, with most of them having constant recurrent exposures to the triatomine, none of them tested positive. And so it was somewhat serendipitous that we ended up looking at one under the microscope. I think I was going to take a nice picture of it. And I found this mite living on it, which was surprising to say the least. I thought maybe I was singing things. And so then we went back to some of the others that we had collected while we were out there, and we found these mites consistently on several of them. And so then in talking with Ed Wozniak, which for those that don't know him, he is the guru, anything that has to do with triatomines. And he said, oh, Melissa, I've been finding that for years, which was fascinating. And he said he's even seen, as you can see in this picture, that these mites will actually live in multiple stages. And so then I went to the scientific literature, and there's 2 articles out there on this, one from Chile, one from Mexico. And they suggest that this is, in a sense, a natural biological control that they theorize, and that it's been shown having these mites living on the triatomines can actually reduce fitness and fecundity. So they're less likely to generate a new, or to generate eggs, and then they're less likely to take a blood meal. They're overall just sicker, and so potentially less likely than to have T. cruzi, which was our hypothesis. So we wanted to know, is this potentially why we're seeing less locally acquired transmission in the southwestern United States, even though we know that people are getting exposed? I don't have a slide on this, but for those that aren't aware, there's a great concern about anaphylaxis in the southwestern United States. So the species there in particular, Protracta and rubida, have been known. Their bites of them can cause very severe reactions. So again, we know people are getting bitten, but they're not having that disease transmission, unlike Texas. So collaborating with colleagues at the University of Arizona and the University of New Mexico, we did a 2-year in the middle of COVID. What could go wrong? We went out and sampled these triatomines to understand if this was a fluke that we saw just at Big Bend, or if this is really something that's more consistent. And so in total, we ended up collecting 3 species. We had rubida, protracta, and recurva, which are common in the area. And as you can see, rubida and protracta both had mites parasitizing them, and they were also associated with T. cruzi positivity, but again, a very low rate compared to Texas. Recurva, we only had 7, and we didn't find any T. cruzi or mites, but that could have been the low number. Interestingly, what we did find was that they could have a large number. That's my fire alarm. Sorry. They can have a large number of mites on them, up to 6 mites. And a couple of things we did find is that they were dispersed throughout the body. So you could find them on the head, the thorax, the abdomen, or the legs. And essentially, once these mites latch onto them, they are thought to be on for life. We had a very hard time even getting them off. We had to develop our own technique for successfully taking them off. We tried to do T. cruzi testing on them, but struggled. So if there's any mite acarologist on here, please follow up with me if you have some thoughts on how you can test for T. cruzi in these teeny little organisms. So in kind of closing, I think where we're at today with thinking about locally acquired disease, There's been 76 officially recognized cases. And as of a couple months ago, it was published in Emerging Infectious Diseases. We now have come to appreciate that there's likely 10,000 estimated cases of locally acquired disease. And again, really, as you can see here, there's some common risk factors that are associated with that. And I believe we're going to do one more poll.
Yeah, Carly, if you could prompt, I think she read my mind. All right. Is rural residents and/or living in the southern USA a potential risk factor for locally acquired Chagas disease? This group is very fast with answers. We appreciate it. All right, I think we've got our results. Carly, if you could end the poll and share those results. There you go, Melissa. 95% said yes, and then some not sure.
Wonderful. Yeah, so there's certainly, again, a wide variety of different risk factors, but in my experience, I would say rural residents is really the biggest impact. And some of that, again, is interrupting that zoonotic transmission cycle. It's also, we've seen several instances of farms where maybe it's not, I wouldn't say a large farm, more of a substance farming kind of smaller operation where you can find them in the hay itself of barns. And I apologize. I think that's my fire alarm, but I texted the fire alarm person, and if no one comes to get me, we'll be fine.
Melissa, do you need to stop? Do you want us to stop? We want to go check.
It's fine. I don't smell anything. I don't see anyone. Don't come get me.
Well, if you suddenly leave, you're okay.
It's okay. I have a couple more slides, so we'll see. So with that being said, locally acquired transmission is really a huge concern and issue. That's something that I'm very passionate as well. But arguably a more important concern when we think about Chagas in the United States is Latinx immigrants. And so a few years ago, we did a study looking at non-ischemic cardiomyopathy patients in the United States that were foreign-born Latinx immigrants and whether or not they have Chagas disease and if it's going unnoticed. And so we worked with one of our larger kind of indigent care hospital settings to recruit this population. And as I mentioned, screening is a huge issue that we have here. So what you're looking at here, we had 14 people that had initially screened positive, 14%. And we did 4 different tests on them. So on the right-hand side, you can see we did our internal stat pack and hemogen. And on the right-hand side, we have CDC's confirmation testing. And so the red is positive. So you can see we had maybe 5 that were consistently positive across all of them. And then the purple is a faint positive, and then you have your negatives. And so it's very challenging. You can see, for example, one of our true positives, so number 37, the 4th row down, was technically negative on our screening test, but then was strongly positive by CDC's confirmation test. So with that being said, my recommendation, I'm not a physician, so I can't give you clinical things, but I would encourage you, if you have someone that screens negative the first time, but your gut suspicion is that they have this infection, I would encourage you to test again with a different test, because the first one could be incorrectly, a false negative or even a false positive. So having multiple tests and confirmation is really important. But in summary, with our non-ischemic cardiomyopathy group, we did find about 7% were confirmed positive, which is lower than another study that was done in UCLA, which found about 20%. But in general, this is a really important patient population to be thinking of in screening. Even though they already have advanced disease and technically would not be great candidates for antiparasitic treatment, there's other cardiac kind of medications we can provide them to help ensure a longer lifetime even with this disease. And then just an interesting take-home message. We found a lot of them were from El Salvador, which led me to start working in El Salvador. And even though I'm not going to talk about that today, there's some really interesting stuff going on down there. And then the last one I wanted to talk about was we are in the process of wrapping up a Chagas seroprevalence study in Latinx residents in South Carolina. There have been studies done in big cities like UCLA and in Baltimore, where we have large populations of Latinx immigrants. But when we think about the reality of most of the United States, most of us live in moderate or smaller sized cities. And so in speaking with clinicians at Prisma Health, that's our largest for the state of South Carolina. We have about 5 million registered patients within this healthcare group. And when speaking with physicians, their concern is they didn't know, since they have a somewhat smaller Latinx group compared to somewhere like LA or Florida, if they should be screening for this, because a lot of these patients are obviously vulnerable. They have healthcare costs that could be very excessive for them. You know, if you have a self-pay patient, you might not want to order the test because it could be very expensive for them. So they wanted some rationale to see if this is something we should be doing in our state. And again, I think this is representative of moderate sized cities. We're about 500,000 to 1 million people per city within this healthcare group. So the first two aims of that study are to just do surveillance. And we ended up getting a grant for this to cover, so anyone's treatment and all of the associated clinical costs with that process are covered for this. We're also implementing a clinical provider education similar to what Paula is doing locally to kind of understand if this is something that had impact for other health disparity related research. And just within the first 71 people we've enrolled, we've already got 6 that were positive. We're still undergoing confirmation testing for all of them through LabCorp, but already I know we've already had 3 at least that have confirmed positive and are starting the pathway. It's been really exciting. I think I saw Norman Beatty's on the call. He's been wonderful in helping train our physicians. So this has been a great process to ensure sustainability in an area that would typically not be thought of for a disease like this. With that being said, I could not and would not want to do this by myself. I'm very thankful. I have some amazing collaborators across the US, including Sue Montgomery, who I saw was on here. She's been a wonderful mentor and supportive coach throughout this process. We've been very lucky with funding. And with that, I would say never stop looking for Chagas disease cases. It's so easy, even a toddler could do it. Just kidding. With any questions, there's my email.
Thank you, Melissa. I love that last photo, by the way.
So
cute, so cute. All right, well, thank you. That was really wonderful. Because of timing, what I'd like to do is, if you do have some questions for Melissa, did your, first and foremost, did your fire alarm stop going off?
It did. We're safe.
Okay, good. I remember at UT Health, they were always going off all the time. So let's see. So I would wondering if it would be okay if we have people put in the chat any questions or comments or thoughts. And then what I'd like to do is Dr. Zhu is going to go ahead and introduce Natalie as our next speaker, or Dr. Bowman. And we'll go ahead and move on into this case presentation aspect. But again, lively conversations in the chat would be amazing. And then at the end, we should have some time for some live conversations too. All right. I'll pass it to you, Dr. Zhu.
Yes, good afternoon, everyone. So Dr. Natalie Bowman is from the University of North Carolina, and her research focuses on 2 main areas, tropical medicine, and in particular, the vector-borne and zoonotic parasitic diseases, including Trypanosoma cruzi, Zika virus, and toxoplasmosis, as well as emerging infections such as Zika virus and SARS-CoV-2, which is the virus responsible for COVID-19 disease. So Dr. Bowman, the floor is yours.
Sorry. Hi, thank you. And Melissa, thank you for what is always an interesting talk from you. Always a hard act to follow. So let me see if I can appropriately share my screen. I have made a last minute change to my title slide to show that you really do have to, can you all see? You really do have to start educating future doctors of America early. So here we have my daughter learning about Nicaraguan triatamines. This was a while back, but so I agree with Melissa, you got to start them early. My talk is Seek and You Shall Find, Diagnosing and Treating Chagas Disease in North Carolina. And I'm just going to do a kind of brief overview of clinical Chagas disease and kind of who should be screened, leading off of sort of what Melissa has talked about, and then present a few cases that we've seen in North Carolina. And our patient population is relatively similar to South Carolina's, which makes sense. We have smaller cities, a lot of rural immigrants. And my talk's more going to focus on imported disease or disease in immigrants. We don't see a ton of autochthonous transmission in North Carolina. Let's see. I'm having trouble getting it to advance. Okay, is it advancing?
No,
Not
we're not
yet.
seeing it. Click again, maybe.
There we go.
There we go.
Now? Okay.
Yep.
So just to briefly overview the clinical evolution of Chagas disease. So early infection is usually asymptomatic or non-specific, and endemic areas generally vector-borne, although there are various other methods of transmission, such as congenital, contaminated food, that sort of thing. Very few people are actually severely ill in most vector-borne infections. And in childhood infections, kids always have a fever, some sort of non-specific flu-like symptoms, and so it's rarely high on the differential. So often not diagnosed during the acute stage. So it can present with a chagoma, which is a swelling at the site of the inoculation site, or if it's in the ocular mucosa, it's called Romagna sign, which you can see here in this picture. And after 8 to 12 weeks, the acute illness resolves and the indeterminate, which is sort of a latent phase, begins. And for most people, this is lifelong. However, approximately 30% of people will ultimately progress to chronic Chagas disease. So the indeterminate stage is characterized by positive serology, but no signs or symptoms of the disease. It's rare to be able to detect parasites on blood smear during this stage of the disease, but patients may be Pcr positive, since it's a more sensitive method to detect parasites, but they are still capable of transmission of the infection, both through vectors or through other methods such as blood transfusion. So as I mentioned, most people will stay in this stage throughout their life, but up to 30% or so will develop chronic Chagas disease, most commonly cardiac disease, but in some areas of the world, GI disease is fairly common, particularly in Brazil and the southern cone of South America. So cardiac disease can manifest with cardiomegaly, as you can see in this chest x-ray. This patient has a very large heart, and you can also see a pacemaker implanted. Arrhythmias are characteristic of Chagas cardiomyopathy, particularly right bundle branch block and left anterior hemiblocks, ventricular tachycardia, heart blocks, and then progressive heart failure. Apical aneurysms of the left ventricle are common. These can form clots, or clots can form in the left atrium in patients who may develop atrial fibrillation, for example, and these can lead to stroke. And about 2/3 of the patients who die of Chagas cardiomyopathy die suddenly, sudden cardiac death, often without even knowing that they had the disease. Another 25 to 30% will die of heart failure, and about 10% from strokes or complications of strokes. Gastrointestinal disease, as I mentioned, is mainly found in Brazil and areas south of the Amazon, is less common and only affects about 10 to 15% of infected patients, and generally presents with these mega visceral syndromes, as you can see in what I think is an autopsy specimen. And it's thought to be caused by destruction of the parasympathetic nervous system to these organs. So some other less common forms include congenital infection. About 5% of infected women will pass it on to their children, often symptomatic, but can present usually sort of non-specifically, like a lot of other torch infections, similar to congenital CMV or congenital toxoplasmosis. Oral transmission is a more recently recognized form of the disease, and generally occurs when has generally been described in kind of outbreaks, often associated with parties or weddings or something like that, where the group has made juice from sugarcane or from acai palm leaves or palm berries, and the bugs are either in the vegetation that's been ground up, or their feces have contaminated it. And if they're not pasteurized, can then pass on parasites that are in the fecal contamination to people who drink the juice. It appears to be more severe than acute infection by the vector, probably something to do with inoculum size, and potentially by something. It's possible that stomach acid may facilitate infection. The pathophysiology I don't think has been well worked out. But they frequently present with fever and myocarditis. And the symptom rate seems to be higher than it is with vector-borne disease. And then immunocompromised hosts usually present with reactivation of latent Chagas infection, and have become more common with transplants, cancer treatments, being offered in endemic areas. So HIV-infected patients will often develop skin or neurological manifestations, particularly meningoencephalitis. It can look a lot like toxoplasmosis as well. Heart transplant recipients may present with fever, myocarditis, skin lesions, but in general, patients who are transplanted for Chagas cardiomyopathy have very good survival post-transplant, probably because they tend to be younger and have fewer other medical comorbidities than other heart transplant patients. And then acute infection in transplant recipients can be very severe. And in general, we don't recommend accepting especially hearts from donors who are Chagas seropositive. Unfortunately, we don't really have any way to predict what patients who are seropositive but in the indeterminate phase are going to progress to Chagas cardiomyopathy. So there have been a bunch of observational studies, and including this study by Rossi et al. From the New England Journal about 15 years ago, where they came up with a score to sort of predict mortality in patients who were diagnosed with Chagas disease. But unfortunately, it really just, if you had signs of heart failure, you were more likely to have worse heart failure and death. With the exception of, it appeared that males were at higher risk, which has been found in other studies. But in truly asymptomatic patients with no evidence of heart disease, we still don't have any way to really predict who's going to progress, which is why we like to treat people. So there's only 2 drugs that have been shown to be really effective, nifurtimox and benznidazole. These 2 were only recently FDA approved and to be prescribed in the United States. They've been widely used in Latin America for decades, however. So there is a lot of experience with them. Both require 2 to 3 months of treatment and have really high rates of side effects, especially in adults. It's not easy to get patients through these treatments. And they're both more effective in acute infection and in children, which is the increased efficacy in children is probably a combination of kids tolerating the drugs better and therefore less discontinuation of therapy, and just because kids have been infected for a shorter period of time. They're contraindicated during pregnancy, in patients with kidney or liver disease, people who use alcohol heavily. And there's really no evidence that treating people who already have signs of heart failure, arrhythmias, or Chagas cardiomyopathy will benefit from anti-trypanosomal therapy. So they are treated symptomatically. Their heart failure is managed as I'm not a cardiologist, but as cardiologists would manage any sort of heart failure. There have been some studies that suggest that amiodarone in particular may be beneficial. But again, I don't want to comment too much on that since it's a little outside my wheelhouse. And there was a big multinational trial called the Benefit trial, which failed to show any effect to prevent progression in adults with early cardiomyopathy. And it enrolled thousands of patients and everyone was pretty disappointed. So in general, we don't offer treatment to people who already have evidence of cardiomyopathy at presentation. So who should be treated? So patients with acute and congenital infection, they have the highest rates of cure, and this approaches almost 100% and within a year or so of infection. Children up to 15 years are pretty much universally in all countries treated for Chagas disease. Several randomized trials, most of which are fairly old, but well done, support a benefit of this of treatment. And there's about a 55 to 60% cure rate for kids who are treated in the early indeterminate form. As I mentioned, the benefit trial showed no clinical benefit. It did show that PCR of the parasitemia as measured by PCR was more likely to be cleared in patients who received benzonaidazole, but it did not have any clinical impact on their course. And there was a 4 to 6 fold higher rate of discontinuation of treatment in the benzonaidazole group than in the placebo group due to the adverse effects. So it was not well tolerated. So it's unclear if adults with the indeterminate form should be treated. There are no trials that really address this issue, and from what I've been told, the number of people that would need to be enrolled is essentially not feasible. So we may not really ever know. I think most expert clinicians would treat patients up to about age 50 in the absence of other contraindications. And then there is pretty good evidence that women of childbearing age should be treated because it can reduce the risk of congenital infection in future pregnancies. And this is from the benefit trials, the Kaplan-Meier curves basically just showing that there's no benefit over 7 years out from treatment. The curves essentially overlap. So moving on to kind of the epidemiology of who has Chagas disease in the United States. So there's a lot of people who probably have T. cruzi living in non-endemic countries. And so the endemic nations are these in gray, in light gray here in Mexico, Central America, and South America. And then the countries with the highest numbers of T. cruzi infected immigrants living in them are the United States with approximately 300,000. Spain, which has somewhere north of 50,000 people living there. Italy has a lot. Several other countries in Europe also have a lot of Latino immigrants who may have Chagas disease. So in the US, there's currently about 52 million Hispanics, and they've accounted for over half of all US population growth since 2010. But most of these were US born Hispanics, and so not at no risk since congenital infection can occur in this group, but at a fairly low risk. But more recently, there's been a huge increase in immigration across the US-Mexican border in the last year or so, especially from countries other than Mexico, which is a little bit of a shift in the demographics from prior years. So especially South Americans, a lot of Venezuelans fleeing political strife, Nicaraguans, other South Americans. And so we are seeing an increase in immigration from endemic areas. The most recent paper looking, and I know some of the authors are on the call, the most recent estimates of the number of T. cruzi infected living in the US, about 288,000 infected with T. cruzi, of whom about 57,000 have cardiomyopathy. 43,000 of these are probably women of childbearing age. And so this produces, a pretty broad estimate, but 22 to 108 congenital cases per year, essentially none of which are diagnosed. And then, as Melissa mentioned, there's about 10,000 US acquired cases living in the United States as well, so not insignificant number. This map shows the number of estimated T. cruzi infected people by county. And so, as Melissa mentioned, the Southwest and Texas really are the areas where there's the most number of people living with Chagas disease right now. There's a large Hispanic population there, plus that's where most of the local transmission also occurs. But there are hotspots all over the country. I had no idea that there were so many people living in the Pacific Northwest with Chagas disease. around the DC area, there are a lot. There's also some Bolivian populations that tend to live right outside of DC. Right along the North Carolina, South Carolina border, we have another hotspot, and then of course southern Florida, which is a big destination for many immigrants, and then northeast cities, of course, also big destinations for immigrants. There's been several studies looking at different populations. Some have looked at sort of tried to do a population-based estimate. Others have looked in cardiology clinics looking for seroprevalence of Chagas disease in Latin Americans. And it varies pretty broadly, anywhere from 1 to 20%, depending on what population you're looking at and where the study's done. But we don't have any great true population-wide estimates, I don't think. So the recommendations for who to screen would be people who have who were born or lived at least 6 months in an endemic country, have a family member with Chagas disease, so in particular a sibling or a mother who has Chagas disease. People who have lived in housing made of natural materials, which might serve as a refuge for triatamines in endemic areas, or people who have reported exposure to kissing bugs, particularly finding them in their home or being bitten. And this could include people who might have either occupational or recreational exposure through camping or hunting or something like that. And then I won't go through through this algorithm, but basically you need 2 tests, two positive tests to confirm infection. And if they're discordant, you would usually want to get a 3rd test to kind of discriminate. There are also several cardiac findings or events which should trigger you to think that potentially an at-risk person might have Chagas disease. And then in North Carolina, so we don't see a ton of Chagas disease here. And I think a lot of that is because we're not looking for it. So in my clinical experience over about the last 10 years, I've come into contact with about 15 confirmed cases. And then several people have been referred to me who had a positive screen during blood donation, which turned out to be a false positive. And those were generally people who had no epidemiological risk factors. Of the 15 that were confirmed, only 2 were US born. One was infected during extensive travel in Costa Rica, I believe, where she had lived in sort of primitive housing, spent a lot of time in wildlife areas. And this was actually written up as a case report, not by me, by some colleagues a few years ago. And then we more recently had one presumed autochthonous case. She had really only lived in the Southeast United States and had no risky behavior since she had moved to North Carolina, potentially was infected in Florida when she had done some camping. We never really figured it out, but her serology was confirmed, and so we did treat her. So we also had 2 women who were diagnosed via cord blood bank screening. Screening in prenatal clinics is not universal. Some do it, some don't, but the cord blood banks do tend to screen for Chagas disease. And so a couple of women have been picked up that way and referred after delivery. And then unfortunately, therapy switch or discontinuation was really common among the patients who did get treated, and it was essentially always due to side effects or allergies to the medications. So the North Carolina Hispanic population is increasing. It's one of the faster growing areas of the country. It increased by almost 300,000 people since 2010. And our demographics, it's primarily immigrants from Mexico and Central America, and a lot of them are from poor rural areas that may have higher focal risk of Chagas disease than their countries as a whole. We additionally also have a large guest worker program in agricultural industries, so people who will come for 6 months, work in tobacco, soybean, and sweet potato fields, and then go back home. And they essentially get no screening either. So I think we're missing a lot of cases.
And Dr. Bowman, this is Paula. Just a quick letting you know we have about 5 minutes left.
Okay, great. So I will go to cases. So case 1 is a 37-year-old Mexican woman with no past medical history. She was in a Zumba class at her local gym and collapsed. When EMS arrived, they found her in VFib arrest. She was resuscitated in the field, intubated and transferred to our CCU. She had a cath, which was clean. And her echo on admission showed a left ventricular ejection fraction of 30% and an aneurysmal apex. She also was screened positive for COVID in the emergency room, although she had had no respiratory symptoms prior to her presentation. But she was given a working diagnosis of COVID-related myocarditis. But the astute cardiologist thought to send off T. cruzi serology, and it came back positive about a week or so later. This was her EKG, so you can see a lot of PVCs and sort of aberrantly conducted stuff. So would you offer her treatment? Yes, no, or maybe? I don't know if there's a way to do a poll or not.
I think probably the best thing is throw those answers in the chat.
Okay.
Maybe we'll get 75% participation in the chat too.
Okay, so I'll move on. It looks like we have a mix of yeses and maybes, and I'd love to hear discussion, but we actually did not treat her based on the benefit trial and the fact that she had a lot of findings really consistent with Chagas cardiomyopathy rather than COVID myocarditis. And so we felt this was that she was unlikely to get any, she was unlikely to be cured. She was somewhat disappointed about this, but we had a long discussion about it, and the risk benefit seemed more in the risk side than in the benefit side. She did have an ICD placed while she was admitted, and she does not plan to have any more children. She had two kids about 10 and 12 years old, and she said she had no intention of having further children. So we're trying to get her kids screened at their local clinic, and so I've emailed their clinic to kind of try and facilitate that, and counseled her not to donate blood, but did also talk to her about she follows closely with cardiology, that if her cardiomyopathy should worsen, we would potentially want to revisit the issue if she would ever go to transplant. Which brings us to case 2, which is a 49-year-old man who was transplanted with for non-ischemic cardiomyopathy. He didn't have any other major medical problems. Had moved to the U.S. from El Salvador about 25 years prior to his transplant. He did have a brother who had died of sudden cardiac death. And post-transplant, he was initially on maintenance medication with prednisone 10, tacrolimus, and mycophenolate. He took Bactrim for toxo and PCP prophylaxis. He had been on valganciclovir for CMV for a little while, but he developed neutropenia, so they stopped that. And then about 15 to 17 weeks post-transplant, he was treated for acute cellular rejection based on an endomyocardial biopsy, and then presented about 10 weeks after that with malaise, weight loss, and fever. So they did another biopsy. And it showed, so on the left, you see a lymphocytic and eosinophilic infiltrate, which I think they initially thought was a form of rejection, of cellular rejection. And then here in one of the myocytes, you see this little nest of amastigotes. And so what would you do next? Would you do high-dose steroids, rituximab, benznidazole, all of the above, or nothing with close follow-up? Should we do it in the chat again? Getting a lot of different responses. Interesting. So he actually got pretty sick. He subsequently developed altered mental status, and we sent blood and CSF to the CDC, as well as did serology, which was positive for Chagas disease. And his T-Cruzy PCR was positive from both the blood and his CSF, and actually had a lower CT value in the CSF, which was kind of interesting. So I don't think it was peripheral contamination. So he was treated for 2 months with benznidazole, and he did pretty well. He had some mild GI side effects, but overall he actually did pretty well. His mental status cleared up. He felt better, sort of returned to baseline. They also decreased his immunosuppression a little bit, but I think the cardiologists were still a little bit concerned about rejection. So he wasn't really, they didn't pull off too much. The pathologist went back and re-examined his explanted heart and did not see any parasites. But I think we all felt pretty sure that this was a case of Chagas cardiomyopathy, and that's probably unfortunately what his brother also died of. Since he completed his benznidazole, he was getting monthly surveillance PCR for a while, and now we've been doing it about once a year. And they've all been negative. Clinically, he's doing great and hasn't really had any further issues from the cardiac standpoint. But he unfortunately had not been screened for Chagas disease prior to his transplant. And so this kind of triggered a change in our pre-transplant screening policies for at-risk people. And so it is now part of the pre-transplant workup to determine if people should get T-Cruzy serology before transplant. And then I got one very final quick case. It's really just a question. So we have a 53-year-old woman, originally from Mexico, has end-stage renal disease, and she's on hemodialysis, but otherwise in good health. So she came in for a pre-transplant workup for a kidney transplant. Her T-Cruzy serology is positive and was confirmed positive. So how would you manage? Would you treat her now? Would you treat her post-transplant once she's stable? She has her cardiac workup was fine. Or would you monitor with PCR post-transplant and see if she reactivates? Looks like we're mostly getting C's. And this is also what we recommended. So she's actually not a candidate to be treated now, given that she has renal disease, and so the medications would be contraindicated. And I think especially in the US, the general approach is to monitor for with PCR, surveillance PCRs post-transplant fairly frequently in the first year or so, and then less frequently if there are no issues after that. I know some centers in other countries will occasionally treat stable post-transplant patients preemptively, but I think most US centers use a sort of watch and wait approach. But I don't think there's great guidance on that. Not a lot of trials or anything that have really looked at that. So. All right, any questions? Sorry, I think I ran a little over.
Okay, thank you, Dr. Bowman. And yeah, we are a few minutes over, so I appreciate everybody sticking around. Before I go ahead and open it up for any questions for people that can stick around, I just first and foremost wanted to thank our speakers. You all are amazing, and I feel very honored to have you all here speaking for us. And it was a great conversation, and it really highlights the complexities of this disease, the surveillance, the treatment, the understanding, and all the knowledge gaps that are associated with it. So thank you so very much. Quickly, if people could take our evaluation, that would be awesome. And if you're going to get CME credits, we need that evaluation from you, but it also helps us for future sessions. And I'm going to go ahead and leave it open for questions and those that want to stick around. But otherwise, thank you all for joining in, and we appreciate you being here. And I see a couple of questions. Anybody want to have any out loud questions before we sign off.
This is Amanda Kiefer. I was just asking for the serial PCR monitoring as someone who receives those lab reports, wondering, how we would look at that and why or what that does for the patient. But somebody did answer. You're just looking to see whether it seroconverts.
Yeah, because what you're hoping to do is sort of like with CMV monitoring. If you detect it in someone who's previously negative, that might trigger you to treat to try to prevent development of disease.
And if you had a PCR positive, but she was still not stable enough post-transplant, is it just a, decide not to treat?
Because the drugs are tricky, if you've got someone who's, in renal failure or something, you kind of just have to wait it out, unfortunately. I don't think we have other drugs that we could use.
Thank you.
All right, any other quick questions before we sign off? And Carly, there was one last slide. I think it has contact information. Also, if you have any additional questions for the speakers, feel free to reach out to myself or anyone else. There's the last wrap-up slide. And we're going to have our next session with looking at veterinary practices. And that will potentially conclude our One Health series and then moving on to the next topics at hand. Again, thank you all so much. If you do have questions, please feel free to reach out to me. Our UT Health Echo site, where you may have been directed to through the registration, will also have information about these sessions posted. And we have previous sessions and recordings posted there as well. And we just thank you for being here. And thank you again to our amazing speakers. And I look forward to seeing you all soon. Thanks, everyone.
Bye, everyone.
Bye.